Hello everyone, this is Dr. Chandana Vishwanatham. Today in this video, I will be talking about respiratory system for MRCP part 1 and part 2. So in the previous video, we have covered a few things like the oxygen hemoglobin dissociation curve, the pulmonary function tests, and some important points about ABG. So the theory part I have covered, and I will show you the MCQs about how they are framed in Mrcp and how you have to analyze it and how you have to answer them. So in part 1 there can be direct memory based or fact based questions like I described them in the previous video, but in this video I will tell you some of the complicated MCQs that you may encounter during the exam. Fact-based or memory-based MCQs can be answered by repeated revision of the theory part, but this MRCP is an exam where you face some complicated questions and you don't understand things easily. So I will discuss those MCQs. Memory-based or fact-based, you can answer them easily. So as I mentioned in the previous video also, there are many online resources which you can subscribe for. The problem with these online resources is that they are not placed in an order. When I prepared for my part 1 and part 2, I faced difficulty using these online resources because the MCQs are very haphazardly placed. You get suddenly MCQ from pulmonary function test, you suddenly get an MCQ from COPD, after that the lung transplant. There is no specific order or anything that they are placed in, so that made things difficult for me because I did not know which topics I covered, which topics I left. That was completely confusing. So that is why I'm trying to make videos which are placed in order so that you can have an idea about how far your preparation is done and what else is needed to add on. And these videos are mainly for people who are not able to afford those expensive online courses. So please subscribe to my channel. That will encourage me to make more videos, and add yourself into the Telegram group that I have mentioned below the video. So let's start with the MCQs. So this is the first one. A 60-year-old patient presenting with complaints of shortness of breath, which has increased over the past 2-3 months, and he's a smoker. The blood pressure is fine, the pulse is 74 with an irregular rhythm. He has an hyperexpanded lung fields and bilateral poor air entry. There is quite wheeze and bilateral pitting edema of the ankles. So this is the main question where you have to, whenever you're reading this MCQ line by line, you have to identify which are the important points in this. So he's a smoker is an important thing, he has an irregular pulse is an important thing, hyperexpanded lung fields, bilateral poor air entry, wheeze and pitting edema. So while reading this part of the question, you make your differentials in your mind, so that when you go to the investigations, it will be easier for you to diagnose the condition. So here the PCO2 is high, 7.2 kilopascals. So there is respiratory acidosis. As I told you in the causes of ABG, you can recall the causes of respiratory acidosis, and this is fine. And coming to the pulmonary function test, I want you to focus on this because here the residual volume is 120% and total lung capacity is 110%, and the transfer coefficient is 70%. So most of you might be confused with these percentages because in some questions they give the percentage in terms of as a percentage of total lung volume or total lung capacity, but in some questions they give the percentage as a percentage of expected value. If the expected value of a particular volume or a capacity is 100%, so from 100% the value is given. So here in the residual volume is given as 120%. That means if the 100% is an expected value, it is 20% more than the expected value. So the residual volume is increased in this case. The same is true with the total lung capacity. It is 110%, so it is increased, and the transfer coefficient is 70%. It means it is decreased. So as you can, if you have not seen my previous video, kindly go back and see the previous video, because I have explained the pulmonary function tests, everything in that video. So the condition which has increased residual volume, increased total lung capacity, and decreased transfer coefficient, which goes hand in hand with the TLCO. But there are few exceptions that I have explained where KCO is increased and normal or reduced TLCO. There are a few exceptions, but usually the KCO is decreased and there will be a lower TLCO. So in this case, they have given an X-ray also, but there are only mild hyperinflation in the lungs and the mild flattening of the diaphragm. I will explain the chest X-rays later, but in this video I want you to focus on the pulmonary function tests mainly. So here they did not give us the value of FEV1 or FVC or the ratio, but even without them we can diagnose the condition, because increased residual volume and total lung capacity means there is an obstructive airway disease, and the KCO is 70%. So if you can recall the causes of lower TLCO or KCO, it included emphysema in it. So the diagnosis would be emphysema in this case. The supporting things for our diagnosis of emphysema in this question are shortness of breath, smoking, hyperexpanded lung fields, bilateral poor air entry, wheeze, and pitting edema because of the right heart failure. And you can see the right heart failure features also in X-ray. So my diagnosis would be emphysema for this patient. But how can you rule out the other options is the important thing here, because as you can see, the other options are asthma, OSA, interstitial lung disease, lymphangiomyomatosis. So this condition, lymphangiomyomatosis, is usually seen in a child age group with shortness of breath and recurrent pneumothorax. So this would be unlikely in this case. And interstitial lung disease is a restrictive lung disorder. So the residual volume, the total lung capacity would be low. And also OSA, which is obesity hypoventilation syndrome, it is associated with reduced total lung capacity, and it will only be associated with hypercapnia in severe disease complicated by pulmonary hypertension and right heart failure. So this is unlikely. And asthma, if you can recall the causes of raised TLCO, the first thing that I told was asthma. So the KCO or TLCO is reduced here, so it is not asthma as well. So my diagnosis would be emphysema. So as this is the first MCQ, I have given an idea about how to approach the pulmonary function tests. In Mrcp part 2, you will expect these kind of questions, which are a little complicated, but if you apply your basic knowledge, you can easily crack the MCQ. So before going to the next question, I would like to tell you, get a paper, get a pen, try to write down the MCQ, try to pause the video after you see the MCQ, read the MCQ, and try to write down the important points, and try to write down what your expected answer is. After that, play the video so that it will be an exercise for your mind. You just don't have to see the video and leave it like that. So Going to the next MCQ, you are seeing a patient in a clinic, and unfortunately all the clinical notes in the cardiorespiratory test department are being audited. However, the patient brings along a copy of her lung function tests. The lung function tests reveal the following. So this kind of scenario is made up because the examiner wants you to test your knowledge, wants to test your knowledge on pulmonary function tests only. So they won't give any clinical information here. They only give the lung function test and they ask us to interpret the values. So this is one kind of question that can appear. So in this question, the FEV1 is 0.3, which is significantly reduced, and the total lung capacity is preserved, or it is at the higher limit. So this picture fits into which condition, just think about it. And the corrected transfer factor is 3.4, which is lower TLCO. So from these results, which disease do you suspect that she is most likely to have? Very severe COPD, severe asthma, moderate COPD, non-specific interstitial pneumonitis, and sarcoidosis. So this question is difficult to answer because even if you make a diagnosis, there is something called as very severe and moderate. So as most of you might be able to diagnose this case, this is an obstructive lung disease. It is a chronic obstructive pulmonary disease. Because the FEV1 is reduced significantly, the total lung capacity is preserved, and TLCO is reduced in emphysema and the obstructive lung disease. So from these results, I suspect the patient to have COPD, but there are two things: very severe and moderate. Very severe, moderate, and mild are some of the gradings that are given based on FEV1 percentage of predicted. So I will be talking about COPD and the uh, severity of airflow obstruction in the upcoming videos. But as of this MCQ is concerned and the PFT is concerned, it is enough if you can diagnose the case as COPD. And in some cases, you may be asked to select the most appropriate next investigation or the most appropriate treatment. In this question, the question has stopped at the point of diagnosis, making a diagnosis, but you may be asked for the next appropriate treatment after seeing the pulmonary function test, most appropriate investigation or something like that. So it depends on the clinical scenario. So you may be asked about the diagnosis, about the investigations, about the management. So if you are able to interpret the pulmonary function test and if you're able to diagnose, only then you can or you will be able to move to the next steps. So I will give you another example of another MCQ. So here is a 32-year-old woman who presents to her doctor complaining of increasing shortness of breath. Over the past year or so, she had also noticed that her hands go white and are very painful if she ventures out in cold weather. So I think most of you already have an idea about the condition, which is Raynaud's. On examination, there is evidence of subcutaneous calcifications in the fingers, fine bibasal crepitations, and occasional wheezes are heard on auscultation of the chest. And they have given some investigations, which is anti-nuclear antibody positive, anti-SLC70 positive. Here the important thing is FVC is 3.2 liters and FEV1 is 2.6 liters. So you might be confused about these values in liters because all we have discussed is reduced, increased, the ratio and everything, but we have not discussed the actual values. But I will tell you the actual values. FVC is the normal value in a male patient is 4.75 to 5.5 liters. So the 4.75 to 5.5 in males, and in females it is 3.25 liters to 3.75 liters in females FVC. So here the FVC is mildly reduced. Coming to FEV1, FEV1 normal values range from 3.5 to 4.5 in males and 2.5 to 3.25 in females. So it is almost at the lower limit, it is reduced, but both are reduced. It could be a restrictive lung disease, but if you don't want to remember all these things that are difficult to remember, these numbers and everything, it is easier for you to just do some maths, which is 2.6 divided by 3.2, you get 0.8. Okay, so that means it is 80%. So obviously the ratio is more than 70%. You know that it is a restrictive lung disease. And even if you don't know this, we all know that systemic sclerosis is associated with interstitial lung disease. So simply logic. You don't have to get confused with the pulmonary function test and everything, all the details in the question. I have put this question because there are many things that try to confuse you in the question, but Mrcp only tests your basic knowledge. So don't get confused, don't overthink. So maybe they have given you in liters. By seeing this, you may be confused. Oh my god, what are these liters? I never come across this. All these thoughts will come into your mind, but stay calm. And what is the most appropriate treatment in this case? So as it is systemic sclerosis and SCL positivity is there, and as you think the patient is having lung fibrosis, as the lung function tests suggest a possibility of restrictive lung defect, the most likely management that I would advise is Cummins immunosuppressant therapy, which is mycophenolate mofetil or cyclophosphamide, all these things. So the correct answer is Cummins immunosuppressant therapy. As the options are having inhaled corticosteroids, beta agonists, and long-acting anticholinergic therapies, which are usually used in COPD and asthma. So it is important in this case, this MCQ particularly, to calculate the ratio if it is restrictive or obstructive. The most likely diagnosis for this scenario is a restrictive lung disease, but the examiner may try to confuse you by asking a question where the patient has systemic sclerosis and a chronic obstructive pulmonary disease together. So that in that case you have to identify the condition only by making this ratio, calculating this ratio. I hope it is clear up till now. So let's go to the next MCQ. So here I want to talk about some important thing about this pulmonary function test, which is BDR reversibility, which is bronchodilator reversibility. In these type of questions, they give you FEV, forced expiratory volume, in 1 second, that is FEV1, before the bronchodilator and post bronchodilator. So we have to see if there is improvement in FEV1 after bronchodilator. If that happens, it means the patient is steroid responsive, and these mainly these scenarios are patient of COPD. So here you can see 63-year-old man has a COPD and a 40 pack year smoking history, stopped smoking 2 years earlier. Despite taking salbutamol inhalers 4 to 5 times per day, he is still significantly short of breath and has a chronic dry cough and can only walk 30 to 40 meters and only climb the stairs once a day. So this part of the question is making it clear that the patient is having an uncontrolled COPD. So you don't have to slowly read everything. You can go through it fastly because you have an idea what the examiner is trying to tell you. He's basically telling you that the patient is having an uncontrolled COPD. So the blood pressure and the pulse and the chest is hyperexpanded, obviously. The air entry is good. There is fine wheeze on auscultation. So here is the important thing. FEV1 of 30% of predicted with no evidence of reversibility. So this line is important. from here, from the beginning of the question till here, there is nothing that you need to worry about. The question looks lengthy, but you have to figure out what is important in this question. So according to the NICE, which of the following is the most appropriate next step? Adding a combination of LAMA and LABA inhaler, add a combination of LABA and inhaled corticosteroid inhaler, add a combination of LABA, LAMA, ICS, add salmeterol, add tiotropium. So these are the options. So they have given that FEV1 has not increased. There is no reversibility with the bronchodilator test. So the correct option would be adding a combination of long-acting muscarinic agonist and long-acting beta agonist inhaler. This one will be the correct one. Don't worry, COPD guidelines I will explain in the next upcoming videos. You will then have a good idea about how to manage COPD patient, what is the sequence of adding on the drug therapy and everything. So you don't have to worry about all of this, but there is something called as bronchodilator reversibility that you need to remember, which gives us an idea about steroid responsiveness in a COPD patient. That thing you keep in mind. That's all. Going to the next MCQ. So this is a high resolution thoracic CT of a patient complaining of shortness of breath, shows ground glass shadowing. However, there is much movement artifact. What would be the best test to confirm restrictive lung disease due to a parenchymal disorder? So these are the options: CT in expiratory phase, FEV1, arterial blood gas, chest X-ray, and transfer coefficient. So as you know, the restrictive lung disorders are characterized by reduced lung volume. This reduction in the lung volume can be because of two reasons. The problem can be in the lung parenchyma, or the problem can be due to disease of the pleura, chest wall, or neuromuscular apparatus. So this is the second category. The first category is the lung parenchyma. The second category is the diseases of pleura, chest wall, and neuromuscular apparatus. So if the patient is having a lung parenchymal problem, that will show up in CT scan. But here they have given that there is movement artifact. So they want you to tell about the next best test to confirm the restrictive lung disease, because we all know that CT, thoracic CT, high resolution HRCT is the best test to diagnose restrictive lung disease, which is related to lung parenchyma. But they're asking the next one because they have a problem with the CT. So coming to the options, the CT in expiration phase. This usually shows air trapping in COPD patients. So this is not related to the restrictive lung diseases. And FEV1 is the forced expiratory volume in 1 second. So FEV1, mainly the obstructive airway diseases can be diagnosed. And ABG, I don't think that will help in this patient, because we are not we won't be able to diagnose the condition with ABG. And just X-ray, parenchymal lung diseases are often normal in early stages on chest X-ray, but we already have a HRCT which is showing ground glass shadowing. So I don't think there is a need for chest X-ray now at this stage. So the remaining one is KCO, which is transfer coefficient. This is important because restrictive lung disease have an abnormal KCO. So if you can watch my previous video on transfer factor and transfer coefficient, you will notice that most of the restrictive lung diseases related to the lung parenchyma cause lowering of the TLCO, which is such as pulmonary fibrosis mainly. So this lower TLCO will help us to diagnose restrictive lung diseases. And coming to the KCO, as the TLCO is low, the KCO is expected to be low. But in restrictive lung diseases related to the pleura, chest wall, or neuromuscular apparatus, there will be increased KCO with a normal or reduced TLCO. That is the main exception regarding KCO that I have told in the previous video. Just go back and have a look. That will be easier. That will make things easier for you to answer these questions. these type of questions, because they will confuse you. They will give a lower TCO, TLCO, there will be an increased KCO. You won't be able to answer such difficult questions, because usually the TLCO and KCO go hand in hand, but there are some exceptions uh, where the KCO is more and the TLCO is normal or reduced, which is mainly the restrictive lung diseases caused due to abnormality in the pleura, chest wall, or neuromuscular apparatus. So go through the previous video to understand this question. The KCO is the next likely test that can confirm the restrictive lung disease due to a parenchymal disorder. So the KCO will be low here in this case. This is the next MCQ. This is the same thing that we have discussed till now, the KCO thing and everything. The 45-year-old woman is referred by the GP to the respiratory care clinic with shortness of breath of unknown origin. So nothing like a clue in this question, because there is only shortness of breath which can happen in any patient. So we have to look at the spirometry result to get into to understand the diagnosis. So the spirometry results show KCO 60%, FEV1 by FVC ratio is 90%. By this 90%, we know that obstructive lung disease is not there. So looking at the spirometry result, the KCO is reduced. These percentages are as a predicted expected value. From that, these percentages come. So if the predicted expected value is 100%, this 60% is means that the KCO is reduced. So which of the following is most likely to be the underlying cause of these pulmonary function test results? So as I told you, this means that there is no obstructive lung disease. So the bronchiectasis, you can take that out of the options, and you're left with 4 options. And out of these 4 options, try to memorize which condition has a reduced KCO. Is it sarcoidosis? Is it severe kyphoscoliosis? Is it muscular dystrophy? Is it pneumonectomy? Think of the exceptions that I've told you regarding increased KCO with a normal or reduced TLCO. So yeah, sarcoidosis is usually associated with pulmonary fibrosis. So obviously in pulmonary fibrosis, as I told you, there is reduced TLCO and reduced KCO. But these 3 things comes under those exceptions where there is increased KCO and reduced TLCO. So kyphoscoliosis, the problem with the neuromuscular apparatus, which is muscular dystrophy, and pneumonectomy, these are the exceptions. So these conditions doesn't fit into this question and this pyrometry results. So the correct diagnosis would be sarcoidosis, which is associated with lung fibrosis. I hope it is clear till now. Going to the next MCQ. So this is the next MCQ. A 45-year-old patient presents to his GP with dyspnea and cough over the past week. He also noticed recurrent nosebleeds and crusting around his nose over the past month. He is a non-smoker, he has no past medical history, and he is not on any medication. And the spirometry results are FEV1 is 80%, FVC is 65% of predicted, TLC is 70%, TLCO is 120% predicted, and KCO is 120% predicted. So this is the pulmonary function test that I want you to concentrate, and there are some other supporting investigations as well, such as urine dip positive for proteinuria and blood hemoglobin is 112 gram per liter, white cell count is 11.2 into 10 power 9, platelets is 540 into 10 to the power of 9, which is normal, and MCV is 90 femtoliters, and estimated glomerular filtration rate is 41. What is the most likely diagnosis in this case? So the options are pulmonary hemorrhage, pneumonectomy, left to right shunt, sarcoidosis, neuromuscular defect. So this is the question, and I want you to pause the video, understand it, and try to answer, because we have discussed so many MCQs till now, so by this time you have to be able to answer this question. So try to answer it by pausing the video. So looking at this spirometry, most of you might not understand where to start the interpretation. Always start with FEV1 by FVC ratio. So this FEV1 by FVC ratio, you have to calculate. There is no other way. Otherwise, you can think in this way: FEV1 is 80%, so it is reduced compared to the expected value of 100%. And if we see 65%, it means if predicted is 100%, it is 65%, so it is reduced. So both are reduced significantly. It means the patient is having a restrictive lung disease, and the total lung capacity is also reduced, goes in favor of restrictive lung disease. So, and transfer factor or TLCO is increased 120%. So anything more than 100% is increased, because 100% is what is the predicted value. From that we have these percentages that have come. So 100%, if it is a predicted value, 120% means that the TLCO is increased, and KCO goes hand in hand with TLCO except few conditions. So the KCO is also increased. So the most likely condition in this patient, can you think of the causes of raised TLCO, raised KCO? The causes were asthma, pulmonary hemorrhage due to Wegener's or good pastures, left to right cardiac shunts, polycythemia, hyperkinetic states, male gender, and exercise. So these are the causes of raised TLCO. But looking at the recurrent nosebleeds, crusting over his nose in the past month, and the raised TLCO and KCO, restrictive lung disease. So which is the most likely diagnosis here? It is pulmonary hemorrhage, because vasculitis usually associated with nosebleeds, such as granulomatosis with polyangiitis, could be the underlying diagnosis, and it is also associated with collapse of the nasal bridge, saddle nose deformity. So the most likely diagnosis here is pulmonary hemorrhage. So how do you rule out the other diagnosis? Other options, sorry. One is neuromuscular defect, where the neuromuscular defect can cause a restrictive lung disease, but the KCO will be increased. So, sorry, the KCO will be decreased. I'm sorry, the neuromuscular defect comes under the exceptions, right? So, I also got confused. See, this is how confusing. So, this comes under the exception. So, there will be reduced TLCO with increased KCO, but here the TLCO and KCO went hand in hand, so that is not neuromuscular defect. And the second one is sarcoidosis. It will cause lung fibrosis, so the TLCO will be reduced, but here the TLCO has increased. I agree this is the restrictive lung disease. These three parameters indicate that the patient is having restrictive lung disease, but when we come to TLCO, the pulmonary fibrosis usually have a reduced TLCO, so here it is increased, so it is not sarcoidosis. And pneumonectomy also, I told you in the exception list, there is increased KCO with lower TLCO, which is not this case. And the other option is left to right shunt. As you, if you can remember the causes of raised TLCO, I have mentioned about this left to right shunt, but it does not explain the nosebleeds as adequately as a diagnosis of vasculitis would explain. And we did not have any history of murmurs of ASD, VSD, or PDA in the examination. So this you can rule it out. The diagnosis would be pulmonary hemorrhage, which can cause an increased TLCO and increased KCO along with restrictive lung disease. So this is the diagnosis. So going to the next MCQ. Here is a 35-year-old patient presented with productive cough, shortness of breath on exertion over the past month. He has no personal past medical history, but his father suffered from hepatocellular carcinoma at a younger age. He is a smoker of 10 pack years. On examination, he has hyperexpanded chest, bibasal V's on auscultation. So here are the spirometry results, and they want us to tell the diagnosis which would best fit in with the above results. So FEV1 is 54% predicted, which is reduced. FVC is 82%, which is reduced. Residual volume is preserved, which is 115 predicted, and the transfer factor is reduced, KCO is reduced. Don't confuse this with total lung capacity. TLCO is transfer factor, not total lung capacity, because when the residual volume is more, and if you read this as total lung capacity, you get confused. Why is this low? So don't confuse, this is transfer factor and this is transfer coefficient. This is different from total lung capacity. The abbreviation may look similar, but this has an O in the end, so don't confuse. So by these details, what do you get to know? So the FEV1 is low, FVC is low, it means there is a restrictive lung disease. But the trick here is we have to calculate the ratio again, because 54 divided by 82 is 0.6. It is going in the favor of obstructive lung disease. So it is better you calculate the ratio than by going directly through these values. Don't come into conclusion. It is better you calculate the ratio. So obstructive lung disease is likely, and the residual volume is as expected, it has increased. So, and the TLCO and KCO are reduced. So what is the obstructive lung disease that has a lower TLCO? It is nothing but emphysema. So the diagnosis here is emphysema, and the underlying condition could be alpha-1 antitrypsin deficiency, because in this question he has progressed very fastly because he has complained over the past month. For a smoker who has an alpha-1 antitrypsin deficiency, the progression would be faster. And there is also risk of hepatocellular carcinoma in these patients. So family history is another risk factor for hepatocellular carcinoma for this patient. So the underlying condition could be alpha-1 antitrypsin deficiency causing emphysema. So going to the next MCQ. So this is not an MCQ. It can come as an MCQ. They will give an history which is consistent with Guillain-Barré syndrome, where there will be areflexic quadriparesis following a episode of gastroenteritis, something like this. And they can also give associated autonomic dysfunction like tachycardia or postural hypotension. And the question would be, what is the most helpful investigation to assess prognosis with regard to the respiratory involvement? So the answer would be FVC. It is not FEV1. If it is not the tidal volume or something, don't confuse. It is FVC is the most helpful investigation in assessing prognosis of GBS patients. And respiratory failure, including supervening bacterial pneumonias, is the most important cause of morbidity and mortality associated with this condition. So going to the next one. This is also very important. A preoperative FEV1 of greater than 1.5 liters for lobectomy and greater than 2 liters for pneumonectomy indicates suitability for resective procedures of the lung. So these are the resective procedures: lobectomy and pneumonectomy. Before the patient undergoes the surgery, we have to check for FEV1 if the patient is suitable for the surgery or not. They can give the scenario something like a lung cancer or a aspergilloma where resection is indicated. In those cases, they may ask if the patient is suitable for surgery or not directly, or they may give options something like what is the next appropriate management plan, where surgery is present in the resective surgeries are mentioned in the option. So if the FEV1 is less than 1.5 or less than 2, so these resective surgeries are not done and they are contraindicated. So that can be one of the questions based on the pulmonary function tests. And this is another important thing, which is the diaphragmatic weakness, bilateral diaphragmatic weakness. In the question, they may give breathlessness on exertion, which is more on lying down flat, and it can be associated with sleep apnea, daytime somnolence, headaches, and paroxysmal movement of diaphragm during inspiration. The symptoms are more worse in supine position. This everything is not so important, but I want you to focus on lung function tests. They classically show low vital capacity, which falls further in supine position. This is important. In supine position, if the vital capacity is decreasing and all lung volumes except residual volumes are reduced, this means the patient has a bilateral diaphragmatic weakness. And the gas transfer tends to be mildly impaired with normal KCO. So these are the pulmonary function tests that can be given in the question, and they expect you to answer bilateral diaphragmatic weakness. This is rarely seen in MCQs. Coming to the next one, lung transplantation and PFD. So coming to the eligibility of lung transplantation, there are some set criteria to make the patient eligible for lung transplantation. The patient must be on maximum medical therapy and rated to have survival of at least 5 years and acceptable quality of life for the patient post transplantation. But for COPD patients, the patient has to meet one of the following criteria in addition to these. So in that, they may ask you regarding the pulmonary function test component of the criteria, which is FEV1 less than 20% of predicted, and diffusion capacity of lungs for carbon monoxide, which is DLCO or TLCO, of less than 20% predicted, or uniform distribution of emphysema throughout the lungs. So this is important to remember regarding the pulmonary function test and lung transplantation. There are some other things also in the criteria which can be discussed later. Going to the next one. So as I told you, the scenario can be of a squamous cell carcinoma patient, and they will ask you if the patient is fit for the surgery or not, or what is the next intervention of choice. These can be the questions, and in the question they will mention his spirometry values, FEV1. It is less than 1.5 liters, and sometimes they also give the patient is having a carotid stenosis of 90% of 80%. So by this question we understand that there is no residual function, lung function, post-operatively. So we won't have sufficient lung to function post-operatively because the FEV1 is very low. And if there is carotid stenosis along with this, post-operative or perioperative risk of stroke is high. So in that cases, for squamous cell carcinoma, we go ahead with radical radio and chemotherapy as intervention of choice because the patient is not fit for the surgery. And sometimes patients with N2 lymph nodes during staging are also not fit for the surgery. So that could be a contraindication for surgery in squamous cell carcinoma of lung. And thank you for listening my video, and please do subscribe to encourage me to make more such videos. I am trying to make things easier for you. I've explained all the complicated MCQs that are seen in MRCP uh, regarding the oxygen hemoglobin dissociation curve or pulmonary function tests or EBGs. So my next upcoming videos will include asthma, COPD guidelines, pleural effusion, and also MCQs which are commonly asked, because MRCP is unpredictable. They can anytime bring out new MCQs. It is very unpredictable. But I will make sure that I will discuss the common MCQs so that you can go through my videos and you can easily pass the exam. So subscribe to my channel and please add yourself into the Telegram link that I have posted below the video. Thank you.